Alright folks, welcome back to One Sheet Neurology, where we take one topic of neurology, put it on one sheet of paper to give you a little handy dandy survival guide on your clerkships. In today's episode we'll be talking about ischemic stroke secondary prevention, but first a quick reminder of the causes of ischemic stroke covered in a separate video. You can use the TOAST criteria, or as I like to remember, the ASCO mnemonic, beginning with atherosclerosis of the large arteries, small vessel disease or small vessel occlusion, otherwise known as a lacunar stroke, cardiac or cardioembolic stroke, you always have to watch out for these, big hemispheric strokes, other notably defined etiology of a stroke, and then an unknown/cryptogenic stroke, where there is no identified cause on an extensive workup, or no workup was completed. No matter what the cause of your patient's ischemic stroke is, you're going to want to recommend some lifestyle changes as well as control some risk factors that we can just kind of call ubiquitous vascular risk factors that increase their risk of future strokes. So beginning with the lifestyle factors, if your patient is currently smoking, you need to encourage them to ideally quit or wean down as much as they can, lose weight if their BMI is above 25, increase exercise, 30 minutes 5 days a week is perfect, and then adopt some kind of diet that's proven to reduce the risk of future strokes, namely the Mediterranean or the DASH diets are good ones. Further vascular risk factors, controlling hypertension, targeting blood pressure less than 130 over less than 180 using first-line agents such as an ACE or an ARB, calcium channel blockers, and thiazide diuretics. Targeting A1C less than 7% if they have diabetes using oral antihyperglycemics and or insulin, and targeting an LDL cholesterol level less than 70 using statins, and if needing, adding ezetimibe and or a PCSK9 inhibitor such as evolocumab. Getting into some of our specific management of etiologies, we'll dive into the cardiac or cardioembolic causes, beginning with the most common arrhythmia that will cause a cardioembolic stroke, AFib. You want to determine whether your patient has non-valvular AFib. That'll be managed with a DOAC such as Eliquis or apixaban, versus a patient with a valvular AFib. Reminder that valvular AFib is going to be defined by severe mitral stenosis or an artificial heart valve, and these patients need to be on a vitamin K antagonist such as warfarin. Now, what if you run into the situation where your patient can't be on an anticoagulation? Maybe they have a history of GI bleeds, an intracranial bleed at some point, or they're a frequent faller. These patients should be referred to cardiothoracic surgery for a left atrial appendage closure and or a Watchman device. Similarly, if they have infective endocarditis, they should be referred to cardiothoracic surgery, cardiac myxoma surgery, and a PFO may need to be closed depending on the size of it and the patient's age. If they have a low ejection fraction, they can be managed with aspirin or warfarin depending on the risk benefits of antithrombotic and anticoagulant effects versus their risk of bleeding. And patients with LV thrombus identified on echo need to be on warfarin. For the other defined etiologies, we can talk about vasculitides, both infectious and then autoimmune vasculitis. If it's an infectious vasculitis such as Lyme disease or HSV, you treat the patient with the appropriate antimicrobials, and if it's autoimmune, immunosuppressants with steroids and possibly other agents. If it's a carotid or vertebral dissection, these patients are actually just managed with aspirin. Hypercoagulable states in general need DOACs, though there are other instances that require other agents, such as patients with malignancy, and I should write pregnancy here as well, are managed with low molecular weight heparins. Patients with antiphospholipid syndrome, which is the presence of all three of the below, cardiolipin, beta-2 glycoprotein, and lupus anticoagulant antibodies need to be on warfarin. The case of sickle cell disease shows up commonly on tests because it's managed not with the use of any antithrombotic agents, because the problem isn't a blood clot that's forming, it's a hyperviscous state of sickling cells. So these patients actually need serial transfusions to lower their HbS less than 30%. In the case of a patient with Moya disease and his very narrow carotid arteries, they need to be referred to neurosurgery for bypass surgery. They literally just bypass those really narrow vessels. For unknown or cryptogenic patients, they're actually just managed with aspirin. Now you might be wondering, what if I have a patient that has a stroke that walks, talks, and smells like an embolic stroke, but I can't find any evidence for what would be causing the emboli? These patients, there's also only evidence to treat them with aspirin, believe it or not. No indication for anticoagulating these patients. So just to review, for all of your patients, you'll want to recommend some lifestyle changes, control their vascular risk factors, and depending on their specific cardiac or other defined etiology, manage them as indicated in the AHA stroke guidelines. And in the case that you can't find any reason that this patient had the ischemic stroke and it's cryptogenic, whether it seems like it's embolic or not, there's only evidence to treat these patients with aspirin. Thank you.